Good afternoon. It is 12 noon Manila time, and we're coming to you live from the University of the Philippines, Manila, for the 17th annual Dr. Lourdes Manahan Lectures in Rheumatology. This is a four-part webinar series that will occur every 2 weeks for the next 8 weeks. I am Dr. Heizel Reyes, a professor in the Division of Rheumatology, Department of Medicine here at UPPGH. As participants, you will be muted for the duration of the webinar. However, if you have any questions or reactions, you can place them in the Q&A box and we will address them during the open forum after the lecture or as the lecture goes on. You will receive your certificate of participation to this webinar through your email after you fill up and submit the evaluation form. The link and QR code that is on your screen. Can we have that, please? The link and QR code for the evaluation form and the post-test will be posted in the Q&A box and at the chat box prior to the end of the webinar. Let me just introduce to you the Dr. Lourdes Manahan Lectures in Rheumatology. This is an annual event hosted by our division in honor of the first Filipino rheumatologist, Dr. Lourdes Manahan. Dr. Manahan was the quintessential physician, pioneering the practice of rheumatology in the Philippines, serving in PGH as the only doctor in the arthritis clinic for more than a decade, mentoring internists and rheumatologists as part of the academe, as a faculty of the UP College of Medicine. And she was also a prolific researcher, authoring the case report for the Rotor Manahan Florentine syndrome as a first-year resident in the Department of Medicine. This year is especially significant, not only because it is our first virtual conference, but because this year we celebrate the 100th birth anniversary of Dr. Manahan. To properly welcome us to this virtual conference, may I introduce the dashing chair of the Department of Medicine, Dr. John C. Anueva.
Thank you very much, Heizel. To the Chief of the Division of Rheumatology, Dr. Evelyn Salido, to the Faculty of the Division of Rheumatology, the Faculty of the Department of Medicine, and to all our listeners, especially the family of Dr. Lourdes Manahan, good morning and welcome to the 17th Dr. Lourdes Manahan Lecture Series. It has been 8 months already since UPPGH was declared a COVID referral center. And since then, significant changes have affected all of us. But the Department of Medicine has remained steadfast in its commitment to service, training, and research. On top of all of this, we have had several activities which were designed for learning and educating our students, residents, fellows, faculty, and the rest of our colleagues. Despite the limitations and challenges imposed by the COVID pandemic, we have been very innovative in creating avenues for sharing our knowledge and expertise. I would like to congratulate the Division of Rheumatology for celebrating the 100th birth anniversary of one of our most beloved physicians who had inspired a lot of us to be the best doctors in our respective fields of specialization, especially the rheumatology. Dr. Lourdes Manahan is not only remembered as the mother of rheumatology, but more importantly, a doctor par excellence. Through this series of lectures, we are able to honor her significant contributions, not only to our lives as physicians, but more importantly, to the lives of our patients. On behalf of the faculty of the Department of Medicine, let me extend our gratitude to the family of Dr. Manahan for all her memories that have been shared to all of us. To the Division of Rheumatology, congratulations for continuing these activities annually that definitely would guide our colleagues and help them in the delivery of better care to our patients. To everyone, enjoy the learning and stay safe. Thank you very much.
Thank you, Dr. Anueva, for honoring Dr. Manahan with your words, for your support for this undertaking and of the Division of Rheumatology, and for your leadership in the Department of Medicine during these difficult times. This year, for the LMLR, we are covering the most classic diseases in rheumatology: osteoarthritis, gout, rheumatoid arthritis, and lupus. This week, we will be focusing on the disease that is classically associated with our field, that is rheumatoid arthritis. In advance, we'd like to thank our sponsor, Mega Life Sciences, for making this event possible. Our speaker for this week is none other than Dr. Eric Jason Amante. Dr. Amante, as you can see in the slide, is very well qualified in the field of rheumatology. What this slide, however, does not describe is that he is a second-generation rheumatologist, being the son of Professor Emeritus Clemente Amante, and had the privilege of knowing Dr. Manahan as he grew up. So si Eric, mula babyhood, rheumatologist na. So Eric, please share with us what we can do to partner in the diagnosis and management of rheumatoid arthritis.
Good morning, everyone. Can you hear me?
Very clear, Eric. Maybe just ask you to show your handsome face.
Okay. Okay, wait. I need to share screen. How is everyone? Okay. Can you see me now? Morning, everyone. This is Dr. Amante, and welcome to the 17th Lourdes Manahan Lectures. The title of my talk is Partnership in the Diagnosis and Management of Rheumatoid Arthritis. And I would like to dedicate this lecture to three people. The first, of course, is Dr. Lourdes Manahan, who I met as a young boy, 10-year-old boy, during one of her travels in partnership with my parents. And she struck me as a very loving aunt. And she found this inquisitive, dark little boy, humorous companion. I'd like to also dedicate it to my father, Professor Emeritus Clemente Amante, who stays in my house now. And every now and then, even though he's retired, still wants to round and admit and discharge patients. He's a true lifer in the College of Medicine and a mentor to so many people here. And finally, I'd like to dedicate this lecture to my mother, who passed away on May 10. And she loved the section and everyone within it and all the trainees so much. So these are my disclosures. Okay, so what are we going to talk about for the next 35 minutes? We're going to understand the classic and current concepts of RA and how it evolves. We're going to diagnose RA in a timely and accurate manner. We're going to assess what options we have for treatment and guidelines in our RA patients. And we're going to try to develop partnerships among physicians to optimize management of RA. So, the magical question, what exactly happens in RA? It's funny because when my patients ask me this, sometimes I really answer to them, I'm still not sure, despite the billions of dollars which have been given or used in terms of research for rheumatoid arthritis. But I'll try my best today. So if we look at a contextual framework for the pathogenesis of rheumatoid arthritis, what we see is some patients who have a predisposing factor or environmental or genotypical predisposition towards the development of RA. I'll be expounding a little bit more on this later, but environment, we know about smoking, microorganisms, and stress. For the genotypes, we're very familiar with the HLA-DR4 allele, and there are other genes involved, such as CTLA4, PTPN22, and a lot of other genes and cytokine genes. It's very fascinating because rheumatoid arthritis often will go through a pre-articular, preclinical, or lymphoid phase, where patients are actually already developing autoantibodies, such as the rheumatoid factor and anti-CCP antibody, years before they actually develop disease. A wonderful study in the US Veterans Group looked at their blood 10 years prior to onset of rheumatoid arthritis and found autoantibodies present 10 years prior to initiation of actual clinical disease. Rheumatoid arthritis goes through a transition phase, and again, it's a little bit unclear. There seem to be microbial insults, biomechanical events, neurological events, and microvascular dysfunction which occur, and I'll expound on that a little bit as well. And of course, the articular phase, where the joints are involved, and we have other problems which arise, such as cardiovascular disease, osteoporosis, and eventually functional decline and disability. So in 2020, a wonderful journal, if you want to read it, it's Clinical Experience in Rheumatology 2020. I chose environmental factors because I think they're extremely relevant to everybody listening, and you'll find this very interesting. So we know that the risk of developing RA is associated with active smoking, and now it's being established that it may also be increased by passive exposure to tobacco. Both inorganic and even organic dusts. So for inorganic, we're talking about asbestos, silica, but organic dust, such as animal and textile dust, may also be involved. And data has shown that inflammation and damage of the asthmatic airways may also contribute to rheumatoid arthritis development. Now, whether these stimuli cause changes which lead to citrullination eventually has been debated as well as a possible pathogenesis for this. In terms of infection, one of the buzzwords now is Mycobacterium avium paratuberculosis, which may play a role in RA by inducing a dysregulation of macrophages and triggering citrullination. One of the most interesting things for us in today's world would be the fact that respiratory viral infections, such as parainfluenza, metapneumovirus, and notably coronavirus, may be novel risk factors for developing RA as well. In terms of other risk factors, a meta-analysis clearly confirmed increased risk for rheumatoid arthritis in overweight and obese patients. And data has shown that these patients, especially in naive RA, have shown increased follicular synovitis and sublining inflammatory cells compared to normals. So there is an increased risk for patients who have high BMI or are overweight and obese to develop rheumatoid arthritis. We're going to go through a little bit of basic science. I know it's lunch, but I'll keep it brief. One of my favorite topics, of course. So what leads to this process? If we look at it in a cellular level, the pathways leading to activation of synovial T cells in rheumatoid arthritis are somewhat illustrated in this slide. So these can be influenced by antigen presentation, co-stimulation. The naive T cell can also be influenced by Toll-like receptors and their stimuli, and by cytokines, which are floating around. So cytokines, which you will see have a prominent role in rheumatoid arthritis and in the next few slides, are merely proteins, right? cytokines. So these are from the Greek derivative, which mean cell and movement. So these are proteins which move around and cause effects in other cells. That's about as basic as it can get. So cytokines such as IL-6, IL-12, IL-23, and TNF-alpha can influence these naive T cells to develop and activate into important activated T cells, such as Th1 and Th17, which then will unleash a plethora of effects, such as cytokine release, cell contact mediated activation, help other cells like B cells, and induce cytotoxicity. A very busy slide. I'm going to walk you through it, and I'm going to compartmentalize it. So this is just an overview of cytokine-mediated regulation of synovial interactions in rheumatoid arthritis. On the left side of the slide, you see our adaptive responses with T cells, B cells, and on the right, we have the innate response. And of course, the central cell here is the macrophage. So if we look at T cells, first of all, we actually already mentioned that it's driven towards a T helper cell and Th17 cell phenotype in the presence of other cytokines and other factors. And this will drive inflammation via IL-17 release, TNF-alpha release, and important cognate interactions with macrophages. What about B cells? So B cells are obviously important. We're all familiar with the fact that rheumatoid factor and anti-CCP antibodies are a product of B cell lineage. So the B cell differentiation and expansion is supported in the synovial tissue by several things, such as IL-6, IL-10, B cell activating factor, and a proliferation-inducing ligand. And B cells have a very critical role as well in synovitis, as they synthesize autoantibodies, are important as well in antigen presentation, and also in cytokine release. A focal point for what's happening in rheumatoid arthritis, of course, is the macrophage. There's several cells involved, of course, in rheumatoid. It's a veritable soup. But the macrophage is important because from it are derived so many interactions through cytokines, such as TNF-alpha, IL-1, IL-6, and others such as IL-15 and IL-18. Which drives so many pro-inflammatory pathways in synovial tissue. If you look at the top of the slide, it can affect the osteoblasts, osteoclasts, the chondrocytes causing cartilage damage, the synovial fibroblasts leading to hyperplasia, the adiponectin, TNF, and IL-6 cytokines will affect adipocytes, and this results in things like atherogenesis and metabolic syndrome. I remember being a young fellow and making an abstract on rheumatoid arthritis, and I was shocked to learn that the risk for morbidity and mortality was equivalent to that of uncontrolled hypertension. And other things are released, such as VEGF, which can lead to angiogenesis. So the macrophage is a focal cell in this entire soup of inflammation, and this inflammation self-perpetuates. So these cytokines talk to each other, talk to other cells, and thus that's why this becomes a chronic illness. Let's look at an overview again of the cytokine-mediated regulation in the idea that pathogenesis leads to potential treatments, right? So what have we found from bench to bedside? What we have found is that early intervention, for example, with TNF-alpha blocking agents and other medications appear to offer higher clinical response rates and improve your chance of achieving clinical remission. So many other cytokines are being targeted. If you go to our conventions, you'll see dozens upon hundreds of different abstracts on different cytokine targets for rheumatoid arthritis. Now, if we go clinical, the question is often for a lot of you, what is in front of me really rheumatoid arthritis or not? From medical school, we know we have a concept of rheumatoid arthritis as a chronic polyarthritis, inflammatory, involving small joints and often big joints as well, often with inflammatory markers. But sometimes reality is different from what we read, right? So patients come to us and we're not really sure. So let's look at a few of these cases. So if a 50-year-old male, for example, presents to you with 3 months of tenderness and swelling of the right wrist, left elbow, ankles, and the right third PIP joint, in the context of a normal ESR 3 times already, you might say, well, this might not be RA. Or a 45-year-old female with intermittent 2 to 3 day bouts of inflammatory arthritis in the left and right wrist, right knee, ankles, and MTPs occurring every month for the last year. This patient, of course, in the Philippines, everybody assumes that any form of arthritis is due to uric acid elevation. This patient has a consistently normal uric acid. Or a 70-year-old guy with 1 month of low-grade fever, left knee pain with no swelling, wrist tender swollen, second PIP, right tenderness, bony deformities on DIPs and PIPs. So the question is, which of these patients has RA? So who says it's the first, who says it's the second, and who says it's the third? I want you to reflect on that question. Well, generally, when we're trying to figure this out, we try to see what's the typical characteristic of patients with RA, and specifically, what are they like in the Philippines? So if we look at a case profile of 266 patients from PGH, which Dr. Penserga first authored, these patients fulfilled the 1987 or previous ACR criteria and were entered to RADAR, which is our registry. And what did we find? A lot of females, 9:1, mean age of onset about 44. And importantly here, duration of illness at diagnosis was 5.4 years, but the first consult occurred 2.4 years after illness began. So it tells us already that patients are not coming to their doctors early enough, and they're not even being diagnosed early enough. If we look at these patients, their symmetrical polyarthritis has a positive rheumatoid factor in about 2/3 of cases, a high disease activity score. A lot of them have hypertension, TB, and diabetes. And if we look at the treatments, most of them are given oral steroids, non-steroidals, and prednisone. And of course, we're given methotrexate. In this cohort, an average dose of 8.6 milligrams per week, and about 1 out of 10 received biologic agents or targeted therapy. If we look at the current criteria for rheumatoid arthritis, this is what we use, the 2010 ACR-EULAR classification criteria. In this criteria, evidence of definite clinical synovitis is a 6 or 10 or above score, and you have to have swelling in more than one joint, and this would classify as definite RA. This is a very sensitive and specific classification criteria that I encourage you all to use. If you look at the left side, joint involvement is measured from 0 to 5, depending on how many joints you have involved and which joints are involved. For serology, you get more points for a high positive rheumatoid factor or anti-CCP antibody. Acute phase reactants such as abnormal CRPs or ESR count for a point. And of course, duration of symptoms more than 6 weeks count for a point. So if you have more than 6 points in this criteria, you are classified as a definite RA patient. But why the variance? Why do we wonder? Why do we hesitate and still think about whether a patient has rheumatoid arthritis? Well, there are several factors. For example, age. Just last week, I saw a patient, no, I think it was Monday, I saw a patient who was 87 years old and shows up with symmetric polyarthritis and a positive rheumatoid factor. But sometimes when people are that old, we don't think of them as having rheumatoid arthritis. Gender. So patients, I have several male patients of rheumatoid arthritis, but sometimes because of our decisions and our thought processes, we don't consider that in males. How about speed of presentation? So as we well know in the field of rheumatology, sometimes patients present at different speeds, meaning they initially present, they're lost to follow-up, and a year later, they actually have symmetric polyarthritis. The time of consultation is very important. Sometimes we see patients, quote-unquote, too early. Sometimes we see patients, quote-unquote, too late. But often, if it's too early, we can't really tell. We have some sort of undifferentiated arthritis, And sometimes we don't consider rheumatoid arthritis at this early stage. And then the patient doesn't show up in our clinic or goes to another doctor, and then precious time gets lost. And of course, there are confounders. They have other diseases, which make us wonder whether they have something else, perhaps a systemic illness. To make things more confusing, clinical manifestations of RA are multiple. They can present with ocular symptoms such as episcleritis, scleritis, scleromalacia perforans. In the lung, they can present with pleural disease, parenchymal disease. They can have these peculiar nodules, which we call rheumatoid nodules. They can present with vasculitis. They have neurologic presentations. They have pericarditis sometimes, or coronary artery disease. We've talked about the musculoskeletal changes. And often you can see patients with anemia or even thrombocytosis because of inflammation. So there's this myriad of manifestations of RA which occur in these patients. So eventually, if your question is, among the patients I showed you, which of them actually developed RA? Well, the answer is eventually all of them did. So it just takes away these stereotypes we have and makes us more conscious of following up patients to see if they actually developed a disease which meets the definitive criteria for rheumatoid arthritis. Okay, so in this part of the slide, well, I would probably take a break in real life and ask you to stand up, but we're all in Zoom and I don't really want to see what you guys are wearing, so I'm just going to proceed. And this slide shows partnership. And I think it's extremely important. Medicine is a very social practice. And I think it's extremely important that we, as physicians, partner with each other in all forms so that we can optimize treatment for our patients. Does improving patient flow of patients with RA actually improve health outcomes and reduce direct costs? I would like to reference a study from Austria. And what they found was that an Austrian primary care physician, or GP, only sees 0.4 patients with RA per year. And if you think about that, when you don't see, if you think about your friends in this lockdown, if you don't see them and you see them with long hair after 6 months, you're just shocked. You almost don't recognize them. Or when we're walking around the hospital, right? We don't recognize each other because of our PPEs. So it's well established that diagnostic accuracy is a function of frequency of seeing a disease. And so this is where people are often behind the 8 ball with rheumatoid arthritis. We've already described that it's not a straightforward disease to diagnose due to its nature and epidemiology and presentations. A GP who sees a patient with symptoms of RA is faced with 2 courses of action: watchful waiting, which most likely will include a blood analysis, prescription of painkillers, and a follow-up appointment, and or immediate referral to a rheumatologist. Now, what the studies have shown is that on average, RA patients visit their general practitioner or PCP 3 times prior to referral on average. And that period of time may or may not influence whether these patients are diagnosed early. For example, they might be seen within 3 times, but in a very short time frame. But in general, patients get seen several months after again. And so there is some delay in treatment for rheumatoid arthritis. I'd like to segue first that for those of you who are not rheumatologists but are very busy in your practice but would like to examine patients quickly, there are definitely things which we can learn which are shorter or abrogated, such as the GALS, which is a gait, arms, legs, spine screening tool. Takes about 2 to 3 minutes. And there are several websites online, such as those from EULAR, etc., which can demonstrate to you how this very brief but important physical exam can be done on almost any of your patients. Let's go back to patient flow. So generally, again, patient comes, develops arthritis, goes to the GP, presents with whatever he has at that point. So if we have watchful waiting, often we'll do PE. You may or may not do blood tests or radiology, often things like ESR. A lot of my colleagues actually who are not rheumatologists are very astute at this. They already order rheumatoid factors, ESR, CBCs, and sometimes even anti-CCP antibodies. But if this loop sort of goes around a couple of times, then we kind of lose precious time as well. So with a specialist visit, of course, the assessment is RA right off the bat, or if you're not sure, you do more blood tests as a rheumatologist. So the main question in this study was, does this affect direct cost? In Austria, a GP visit is about 27 euros. If you do a diagnostic intervention, the cost of the diagnostic intervention is about 37 euros. And if the patient is referred to rheumatologist, the specialist will bill about 31 euros. So if we multiply this cycle 3 times or more before we go to our rheumatologist, what do we find? So what they found in this study of health economics modeling is that patients, again, were not diagnosed with RA all earliest, so they would often have multiple visits. And the cost impact of this in GP visits was actually, if you do it with quick referral, a cost savings of about 100,000 euros in this population. So yes, actually, referring to rheumatologists early will save time. And don't worry, we will re-refer these patients back to you, as I'll show you later, because you are extremely important in management of several things with these patients as well. Treat to target. So I just put this slide up to sort of humble me and remind me of where I trained in the States. Sometimes they talk about being a big fish in a small pond or a small fish in a big pond, whatever. But every time I walked into this hospital, I felt like a newbie again, because it's just humbling how much research has been done for rheumatology and how much these people inspire you. And so I'm sure that our current mentors in PGH are doing the same to their trainees up to this very day as well. So if we look at foreign recommendations for the management of rheumatoid arthritis, I'd like to show you a 2019 update from Europe. And it's divided into 3 phases. So phase 1 is the initial diagnosis. Often we will start methotrexate if there's no contraindication, combine it with short-term glucocorticoids. If there is a contraindication, we may start back there leflunomide or sulfasalazine, which are unfortunately not available here. Here you might think about using hydroxychloroquine, for example. Patients are assessed in this setup at 3 months and achieve target at 6 months. Now, you may ask, what's the target? So the target is remission. The DAS28 score of less than 2.6. If you want to memorize the formula, there you go. I'm sure none of you really want to memorize that formula. So just think about having almost no swollen, no tender joints, and a normal ESR. If that is achieved, you just continue your treatment. However, what if you don't achieve that? Then you go to step 2 or phase 2. In phase 2, you decide, are there poor prognostic factors or not? If they're absent, you change or add a second DMARD. We've mentioned some of those. If poor prognostic factors are present, then you add a biologic DMARD, such as those targeted towards IL-6, TNF-alpha, etc., or what we call a JAK or Janus kinase inhibitor, which are oral tablets, which are also treatments for rheumatoid arthritis. You reassess at 3 months, achieve target at 6 months. If you do not achieve target at that point, okay, if you do achieve target, then you can continue, and eventually you can actually dose reduce or interval increase your treatments if you have sustained remission as per the EULAR guidelines. If you don't achieve your target, then you go to phase 3. So phase 3, you change your medication, you reevaluate. If you have not achieved target, you keep changing biologic DMARD or JAK inhibitor until you achieve remission. And at that point, again, you can dose reduce or interval increase. So this is a calculator, for example, for DAS28. If you're curious, they're available online. All right, let's talk about Asia. So in Asia, the APLA recommendations for treatment of rheumatoid arthritis, a 2018 update. What did they recommend? It's kind of similar, to be honest. Starting treatment with methotrexate. Intolerant methotrexate, you go to other medications such as hydroxychloroquine. I remember as a child, to be quite honest, I was about 12 years old and I was doing a science project and I had nothing to do. So my dad had some intramuscular gold lying around and I injected some rats with it and passed my course. So that stuff has been around for a long time, but there's been so much development in the field. In patients with high disease activity, combination should be considered. Now, importantly, prior to starting targeted therapy or biologics, one of the things APLAR made clear is that all patients should be evaluated for the presence of infections, other comorbidities which may possibly contraindicate use. All patients should be screened for infection, including TB, hepatitis, viral hepatitis, and HIV. And if you have latent TB, prophylaxis treatment is recommended according to country-specific guidelines to prevent TB reactivation. For RA patients with Hep B infection, antiviral therapy should be prescribed to prevent activation. What about vaccinations? So we get this question all the time. So during targeted therapy, and actually in general, live attenuated virus vaccines are contraindicated or not recommended. However, you can give pneumococcal vaccines, influenza vaccines. Conditionally recommended would be those for Hep B, HPV, and meningococcus. Now, going again to targeted therapies, again, if patients have inadequate response, they're given these biologics, wonderful drugs which really act well to reduce inflammation, sustain remission, and reduce damage to the joint. No? Based on current available evidence, a whole bunch of these targeted therapies are equally effective in the treatment of RA. What are examples of this? I had the pleasure of being involved with a study for this, and as an author for the golimumab study, which was a human anti-TNF monoclonal antibody we injected every 4 weeks. So we're proud to have Filipino patients in this study. This is the subgroups. And what's the important result? Well, at week 52, in the US, they use the ACR criteria. And at week 52, and further on after, patients clearly had a better response when they used golimumab versus placebo plus methotrexate. Maybe some of you have heard about biosimilars. So in medicine, we talk about generic medication as a sort of equivalent for innovator drug, right? So when we talk about biologics, we have biosimilars, highly similar to, with ideally no clinical meaningful differences in safety, purity, and potency from the existing FDA-approved biologic. Minor differences in clinically inactive components are thought to be acceptable. Several biosimilar DMARDs, or disease-modifying anti-rheumatic drugs, based on TNF-alpha inhibitors, such as etanercept, as well as infliximab and adalimumab, have undergone clinical trials and actually been approved for use in patients with rheumatic diseases such as rheumatoid arthritis. To your right is a picture of etanercept. This is the Planetra study, and I highlight the fact that my colleague, Professor Mike T, was involved with this study as well, a randomized trial which compared innovator infliximab with a biosimilar co-administered with methotrexate, and which resulted in equivalent efficacy as well at week 30 with comparable PK profile. So a very, very fruitful study for biosimilars. For those of you who really like to look at the PK, for example, this is a comparator study between innovator etanercept and our biosimilar etanercept of 3 milligrams per kilogram subcutaneous injections in rats. And what you see here is absolutely no difference determined by t-test. So you can see along the curve, very similar PK study. So this is boding well to some degree for biosimilars because to some degree they are cheaper and hopefully will be accessible as well to more patients as an alternative to existing innovative biologic agents. It's really a whole new world, isn't it? A year ago, I would be talking to you probably in a hall somewhere, right? But then COVID happened. And no, I'm not lecturing to you in shorts, but it's just changed the way we live and the way we practice, right? So I want to show you and highlight some of the changes which have been derived in terms of treatment for rheumatoid arthritis because of COVID. What are the recommendations? So patients who are ongoing treatment, stable, no infection with no exposure, hydroxychloroquine, methotrexate, leflunomide, biologics, JAK inhibitors, basically everything may be continued. Okay, this is from the American College of Rheumatology. Now, you have a newly diagnosed or active rheumatic disease. Again, absence of infection or SARS exposure. For active inflammatory arthritis, you treat with synthetic DMARDs, and if they do not improve based on the guidelines earlier, biologics may be started. This panel noted some uncertainty regarding the use of JAK inhibitors in this situation. What about ongoing treatment of stable patients following SARS-CoV-2 exposure? So no symptoms yet, but they have had exposure. And I can tell you now, I had a patient exactly like this. Walked in my clinic about 3 weeks ago, did her consult, said goodbye. And a week later, we got a call from the daughter saying that she tested positive for COVID. She neglected to tell me, and I guess it was partly my fault. I always ask my patients whether they have cough, cold, diarrhea, anosmia, problems tasting, etc. But I failed to ask her about her husband, right? And so her husband apparently had already been coughing for about a week and a half, was tested that weekend. She was tested along with him, and they both came back positive for COVID. And luckily, she didn't really develop too many symptoms. And I'm lucky to be talking with you today. To be quite honest, I did my own COVID swab test a couple of days ago as well. I've been sick over the weekend, but thankfully that test was negative. And with God's grace, I'm able to lecture to you. But it's the world we live in. So in this group of patients, ongoing treatment, stable patients, following exposure alone with no symptoms, the recommendation is to stop temporarily all immunosuppressants and IL-6 and JAK inhibitors pending a negative test result for COVID or after 2 weeks of symptom-free observation. However, the panel did note uncertainty regarding whether to temporarily stop methotrexate or leflunomide in this situation. And note that this has non-IL-6 biologics because, as we well know, tocilizumab or IL-6 has been used to some degree in treatment for COVID. Now, what if you have rheumatic disease in the context of actual presumptive or documented COVID-19 infection? This is an old recommendation to some degree, but it did recommend that anti-malarial therapies may be continued. We now know the evolving science between anti-malarials and COVID, but the recommendation was to continue that and to recommend everything else which are non-IL-6 biologics or DMARDs should be stopped or held. So I think this is a practice which we can do today. So let's co-manage all of these patients. Why is it important for us to partner with you and to get your input? Because comorbidity is so common and prevalent in rheumatoid, and we need everybody in this room to help us manage other factors in this disease as well. So in a study cohort in northern Sweden, 950 patients included, 726 ill for more than 5 years. Here are the rates for comorbidity, and they're quite high. 27% had hypertension at baseline, and 15% developed new comorbidity during 5 years of disease. 19% had endocrine diseases, and 10.5% developed more endocrine diseases. Myocardial infarction, look at these rates. Malignancies there as well as stroke. So clearly these comorbids occur in these patients with rheumatoid arthritis, and we all need to keep our eyes open in terms of handling them. The risk for heart attack in some studies in England double that for RA patients versus the regular population. The risk for atrial fibrillation 40% higher among RA patients than those without RA. The risk of stroke 30% higher for patients with RA versus not. And interstitial lung disease, we all well know this disease is associated with rheumatoid arthritis. We often screen for that in the setting of ILD, and it is often a major cause of death amongst rheumatoid arthritis patients. Osteoporosis, well known, rates of osteoporosis go up twice as high. And of course, sometimes we give prednisone, which exacerbates these. Cancer, leukemia, lung cancer, lymphoma, and multiple myeloma in this cohort were more common in people with RA. And of course, depression, which is probably doubled now, the rates of depressions are raised among RA patients. So we really need each other's help. One way we can help you is that the PRA has a directory. If you need to find a colleague rheumatologist all over the country, you can go to our website and click on people who may be of service to you. And of course, now in the COVID era, a lot of us are also doing online consults. It's not the equivalent, but it's helpful often in giving each other guidance. to initially diagnose rheumatoid arthritis. We need to diagnose this disease really, really early so we can create more effects on how these patients do long term, prevent disability, prevent destruction of their joints. And it's really a partnership between us and the community of doctors nationwide. So thank you for your attention. God bless and stay safe, everyone. That concludes my lecture.
Thank you very much, Eric, for your lecture. It's very, very action-packed. Right now, we have 265 participants in this webinar and some viewers in Facebook Live. And I'd just like to mention that among our attendees are rheumatologists, internists, former students of Doctors Manahan. So welcome Dr. Wilma Baltazar, Dr. Wee, Dr. De La Vega, Dr. Di Macali, and Dr. Dungo. We have participants from Ilocos to Cotabato. So now we will proceed in answering the questions in the QA box. Thank you for those who have posted their questions in advance. Okay, Eric, can I ask you to show your video now?
I'm trying, I don't think the Lord...
Oh, there you are. There you are. We can see you now. Okay.
Probably
Okay.
better anyway. Go
Okay.
ahead.
So we will start first with a question from our teacher, Dr. Liberty Pahutrao. And this is a very interesting question because you ended up with by mentioning that we need to be able to diagnose our patients as early as possible. So Dr. Pahutrao is asking us, for a patient who seems to have some symptoms that are indicative of RA, how often and how would you monitor these patients?
Well, to be honest, I'm sure that's an advantage we have in the Philippines. We don't have to wait 3 months for our next appointment. So usually we would give them some medication, order our tests, and actually depending on how long your tests would come, no? For example, the anti-CCP antibody may take a few days. I would probably see them in 2 weeks and make the diagnosis there. The earlier we make this diagnosis, the better.
Yeah. So I think the question is, if you have some symptoms, you have some hand pain, you see a doctor and then the doctor tells you, oh, perhaps it's not rheumatoid, but the symptom persists. How do you redo the workup for the patient? Do you repeat your RF test? Do you repeat your inflammatory markers? And how often would you do that?
Yeah, definitely. Again, it's medicine is an art, right? But I think I would keep in mind that this may evolve even over the next month. And so if you're not comfortable seeing them, every couple of weeks, I would say at least a month or every couple of months, especially if the symptoms are very prevalent. Now, the flip side is also something you can do. For example, you can stop your medication. You can give them meds for 3 weeks and say, okay, we'll stop the last week, right? And then let's see what happens. And sometimes when you stop the medication, I learned this early as a fellow, then you see the full-blown picture of the disease come to fruition. So that's another option we have. But yeah, I would say 1 to 2 months. Gone are the days when we spent 2-3 years trying to diagnose patients with RA. So things may evolve quickly.
Yeah. So Dr. Pahutrao is asking all the way from Sweden. It's early morning there, so we have to answer this right. What Dr. Barba is asking, in those cases, is there a role for musculoskeletal ultrasound?
Yes, absolutely. So musculoskeletal ultrasound has been evolving over the last decade. We have wonderful champions of that, both in PGH and all over the country. And it allows us to see changes in the joint early on. So ultrasound, of course, is more accessible than MRI and probably a more practical choice nowadays in the pandemic, right? Because it would probably be quicker to some degree. But yes, it has been shown to be sensitive and specific for showing features which would suggest rheumatoid arthritis. Again, if you look at the Euler criteria, technically it's not part of the criteria for rheumatoid, but it will definitely bolster our belief that someone actually has rheumatoid arthritis and further diagnose and treat these patients accordingly.
Yeah. There's also a question here from Dr. Levilla. Do you see RA among the pediatric age group and how often? And when we're treating people with RA, the question is, do we repeat inflammatory markers? Yes, we actually do monitor the inflammatory markers before stopping treatment. So what about pediatrics?
Yes, so pediatrics, For me, technically, we know there's a disease called juvenile idiopathic arthritis, used to be called JRA. We have experts, I think, in the audience. I know Cherika's there. So we actually have pediatric rheumatologists whom we can definitely have interact with you, or you can partner with. To be quite honest, a lot of us adult rheumatologists, I think some of you will echo this, do see patients because our patients are their parents or their lola, and then they end up showing patients to us who seem to be developing inflammatory arthritis. So again, more common in that age group, we would look for JIA and lupus and dermatomyositis, things like that. Now the question is, does this turn into adult RA, right? Well, I can tell you offhand, I have a patient. He's now probably in his 40s. When I first met him, he was about 30. He had JIA until about 19 or 20, and his arthritis got quiet. And so he said, I'm just stopping all my meds. I'm fine. I don't have any arthritis. When I first met this guy, he was a rich guy. He had already had bilateral knee and hip replacements in
Oh, wow.
Stanford Hospital. Yes, because, and it shows to me, and he now has problems with his ankle. So it shows to us that you can have cases illustrative of actual adult RA in patients who initially were diagnosed with juvenile idiopathic arthritis. I've seen it with my own eyes, so yes, that does happen every now and then.
Okay. We have a lot of questions in our Q&A box, so we'll try to answer them super fast. Okay. The first question, for patients, because you did mention in the pathogenesis that T cells seem to have an instrumental role in pathogenesis. Does that therefore mean for patients with low T helper cells, like in HIV, there is some protection against rheumatoid arthritis?
Wow, that's an interesting question. I would probably not go that far in saying that there's protection from rheumatoid arthritis, especially since it's such a heterogeneous disease and other factors come into play.
Okay. So what about if your resources are limited? How do you do the workup if you suspect somebody to have RA?
To be honest, I would do great history and PE, probably do an ESR, right? See how many weeks they have a disease, and maybe do a rheumatoid factor, and that's it. And with that alone, you can diagnose people based on EULAR criteria.
In fact, if you use the ACR EULAR criteria, the clinical findings have a lot of weight. No? So you can make a very strong diagnosis based on that. The next few questions, we're going to do them rapidly, is on treatment. What success do you get? What success do you get in terms of receiving, getting into remission? I think let's ask it first. In the olden days, or with traditional conventional management, and now.
Okay, well, I'll segregate that into taking oral medication like DMARDs, such as methotrexate, plus minus prednisone, NSAIDs. I tend to use methotrexate at a higher dose, so I go somewhere between 15 to 25 milligrams weekly if patients can tolerate it. In that setting, I would say at least half of these patients actually do very well or even achieve remission, although that remission can be fleeting, meaning it can fluctuate, right? And if patients are frequently having problems with that, we go to biologic agents. Even on biologic agents, all of the studies show that not all of the patients will respond to one biologic. And that's why cycling of medication is important with rheumatoid, so you can maintain or have patients in remission most of the time, if not all of the time.
So it really just means that constant monitoring of patients is very important, right?
Absolutely. Yes. Frequent follow-up.
Frequent follow-up and regular monitoring. So given what you said about methotrexate, there's a question here about how soon do you start methotrexate?
It really depends, no? Because if I see patients who already meet criteria on day one, and some of them do, I'll probably start them on methotrexate if I have normal liver function tests. So, of course, we have to check first creatinines, LFTs. I might, depending on the situation, even check whether they have hepatitis B or C or not, etc. But that would be the prerequisite. If they don't, to be honest, I would give them NSAIDs, a little bit of steroid, and wait for those results to come back before starting methotrexate, perhaps in 2 weeks or a month.
Okay. Segueing to steroids, do you still have patients on prednisone forever?
I try not to keep them on it. Often it will be periodic. What I do, what's very important for all of us here in the audience is to establish with them that prednisone really works well to reduce swelling and inflammation, but you will get disability and destruction of your joints eventually. And we have seen this countless times if you just stay on prednisone. Because often they'll abandon everything else, take a huge dose of prednisone, look like, moon-faced people when they walk in the clinic, and yet they can't move their joints anymore because they've had so much destruction.
Yeah.
So prednisone is not the cure for everything.
Correct. Not even for COVID, right? Okay.
Yep.
What about the biologics? How do you choose the biologic to start for a patient with RA?
Well, biologics, there are some studies which suggest that there's equivalence in terms of efficacy among TNF alpha agents, for example, IL-6 agents, etc. So to some degree, you have to base it on patient preference. There's some issues of cost, whether they like injections or infusions, how often do they want their treatment. So because of the large number of treatments now, you can actually pick and choose which one you use for your patient. And then if it doesn't work, you just cycle to the next one.
Yeah. We actually have protocols for switching biologics, right? A couple more questions here. What about prevention? Are there strategies that you can do for patients who seem to have to be at risk, like if they have a family history, like if they're a smoker, the stopping the smoking lessen the risk?
Yeah, I would harbor back to my epidemiology slides, which suggest that passive smoking, avoid, right? Active smoking, obviously avoid. Other irritants to the lung, of course, infections, which we sometimes can't avoid. And, patients who have less obesity and lower BMI have a lower risk as well. So these are some of the things which we can look at. Things like avoiding sunlight, etc., are not things that we do for rheumatoid. That's for things like lupus.
What about food? Somebody's asking about food.
Everyone asks about food. So arthritis equals food in the Philippines. And the answer for me is no. There is no actual study which suggests any integration of food causing rheumatoid arthritis.
Yeah, we will be talking about gout in 2 weeks' time, and you can ask all the food-related questions you want then.
Yes, it's there about that. Yeah.
What about, is it possible for rheumatoid arthritis to coexist with another arthritis?
Yes, absolutely. We've seen cases of rheumatoid with patients with TB arthritis, rheumatoid and septic arthritis. So that's one we really have to be careful about, right? Etc. And then, of course, there's the ubiquitous lupus or rheumatoid plus lupus, and there are patients with features of both diseases, meaning they have lupus, but they have deforming arthritis. So, yes, they can coexist with other diseases as well, kung talagang malas ka.
Okay. Here, a couple of questions from our fellow rheumatologists. Somebody in love with RA is asking, is there any serologic test that you can suggest to differentiate polyarticular RA, especially perhaps hand OA? Polyarticular OA, perhaps hand OA versus RA?
Yeah, well, to be honest, I think OA is primarily a radiographic and clinical diagnosis. So from there alone, we can delineate that. No, there is no blood test for osteoarthritis. Occasionally, you might even see some mild inflammatory marker elevation because of OA evolving in the DIP joint, for example, and the process doing so. But generally, they'll have low ESR, CRP, and patients with RA will have high inflammatory markers, and majority of them will have a rheumatoid factor and CCP. So if they have those changes, positive RF, CCP, and high inflammatory markers, and the right joints involved, of course, then it's probably rheumatoid arthritis. RA does not affect the DIP joint at all. So if that's the case, then we think more about osteoarthritis and perhaps even sometimes psoriatic arthritis in some cases.
Yeah. Another question from a fellow rheumatologist. For RA patients, we talked about methotrexate. And we do know that one of the possible adverse events is actually in the lung. So for an RA patient who develops ILD, do you always discontinue methotrexate, and what do you give them instead?
Yeah, so methotrexate can cause some changes in the lung, which are concerning to some degree. We've had cases in Manila doctors where we just stopped the methotrexate, and 2 months later, you have a normal x-ray. But I think what they're referring to are patients with interstitial lung disease where having methotrexate on board could be a confounder. And in that setting, I agree, you might want to shift from methotrexate to either other DMARDs or a biologic just to keep that part of the story less confusing.
Yeah. We have a lot more interesting questions, but let me just ask the next in a cluster. This is for patients with COVID. Is there any particular drug used in RA that needs to be avoided among patients with COVID? And do we expect an increased rate of RA cases in the future?
Okay, that's a great question. I'll answer the first part. Initially, if you look at the data I showed earlier, patients who do not have exposure, really not much recommendation to stop existing medication, right? If you have an exposure and you have no symptoms, probably more prudent to stop the majority of them, as I showed earlier. And the question about COVID showing us more RA in the future is a very, shall we say, interesting question. It's a moving forward question. I think if we examine cohorts and we see that there is more rheumatoid arthritis among a large cohort of COVID patients compared to the population, then that might come to fruition. Right now, I think it's still too early to give you a definitive answer on that one.
Yeah. Oh, huling-huli na talaga to. There's a pathologist in the room. Ano bang magagawa ng pathologist in helping us care for our RA patients?
Well, of course, for diagnosis, right? We've had cases of patients who were thought to have TB arthritis, right? Or some other confusing arthritis in the wrist, in the ankle, in the knee. And we really need, tissue diagnosis is still very, very important. I still remember being a student and looking at pictures of hyperplasia in the joint, right? And it's fascinating because the synovial layer is only two cell layers thick, right? And in patients with RA, it's very clearly different. And of course, important to rule out active infections as well. And from a lab standpoint, of course, we need your help as a pathologist because new tests are coming about, right? New antibody tests are coming for sure down the pipeline. And the availability and utility of these tests will, to some degree, a lot hinge on the pathology and lab departments. So yes, we need your help too.
Yeah, so this is really a way to partner with everyone here, primary care specialists as well, and specialists of all sorts, no? And especially also our partners in rehab, no? So PT and OT is very important as well for the care of our patients. Okay, I think we've about covered most of the questions. If you have the chance, please go over the Q&A box and see how we've answered some of the questions that were typed in there. Thank you, Eric, for answering all those questions. I'm sure the audience enjoyed your talk and learned a lot about you today. Thank you to our audience for very interesting questions. So for this afternoon, Dr. Amante walked us through rheumatoid arthritis. Thank you for reviewing the classification criteria, the new, not new, 10-year-old classification criteria, but it's constantly new to a lot of our participants. Eric identified the problem of delayed diagnosis primarily because RA is not just really a disease of the joints, but it can cause significant morbidities as well. And it's easier to treat them early because remission is possible. So that first few slides, which were painful to look at because they're basic science slides, are there because these are the primary framework for the medications we have now. And we are improving our care for patients with rheumatoid arthritis, but it is only possible if you're able to help us identify these cases and send them to us. So we would like to thank Director Gerardo Legaspi, Dr. Margarita Latluna, the PGHIT team for making this webinar possible. Our special thanks to our sponsor, Mega Life Sciences. A big virtual applause for you, Eric. Thank you very much for that inspired talks. I'm sure your mom and dad and Dr. Manahan would be very happy. Thank you to our audience for joining us. We hope to see you again on October 28th as we talk about the holistic management of gout with Dr. Ange Magbitang Santiago. There's already questions for Dr. Santiago in the box. We do hope to see you. Please make sure to click the link provided That is for your post-test and for your evaluation. Once you have that and you've submitted that, we are going to be sending you your certificate of attendance for this webinar. It's 1:05 in the afternoon. Maraming salamat to our 200 plus participants, and we will see you in 2 weeks.